Good afternoon, everyone. I'm Kirsten Malloy, Chair of Hunter New England Local Health Districts Board. It's my great pleasure to welcome you to our annual public meeting for 2024 and 2025. I'd like to begin by acknowledging the traditional custodians of the lands we meet on today. For me, I'm on the lands of the Awabakal and Worimi peoples. I extend my respect to Aboriginal and Torres Strait Islander people joining us from across the district. I pay my respects to elders past and present and recognise the richness and diversity of Aboriginal cultures and the deep connections to country across New South Wales. Today, we will share some of our achievements and milestones, our financial performance and strategic priorities, and there'll be time at the end for some questions. This has been a significant year for our district, marked by many important transitions. I would like to acknowledge and thank Associate Professor Martin Cohen, our previous board chair, and Professor Peter O'Mara, who recently completed terms on the board in December and October of last year, respectively. Their commitment and expertise has been invaluable to our community. Our board plays a critical role in setting strategic direction and ensuring patient care, innovation, and community health remains central to our work. The diversity of locations, skills and perspectives at the table strengthens our ability to meet challenges and seize opportunities. So I'd also like to thank Dr. Stephen Pride, Liz Nicol, Kevin Dupay, Bob Hawes, Megan Hudson, Anita Kaufman, Penny Paliadelis and Wendy Wilkes for their continued support and contribution. Their guidance helps shape sustainable and meaningful outcomes for our communities. Ahead of this meeting, 2 of our board members reviewed and adopted the minutes from last year's meeting. I thank Anita Kaufman for adopting the minutes and Bob Hawes for seconding them. I also want to acknowledge our Chief Executive, Tracy McCosker, for her leadership over the past 12 months. Together with her executive team, she's driving significant change that positions us strongly for the future. Over the past year, our district has achieved major milestones. Highlights across the year include launching a custom-built Medibus to deliver specialist diabetes care to towns with limited access, supporting both patients and upskilling local health professionals. We opened a specialised menopause hub in Newcastle, providing comprehensive multidisciplinary care for women with severe symptoms. We opened New South Wales' first residential eating disorders centre in Charlestown, a $13.5 million facility delivering intensive personalised care for people aged 16 and over. We opened a maternity simulation centre at Tamworth Hospital in partnership with Charles Darwin University, strengthening midwifery education and training in the New England region. That said, challenges remain. Workforce sustainability, increasing demand for our services, ageing infrastructure and financial pressures mean we must continue to innovate and adapt. Looking ahead, technology will be critical. Virtual care and outreach are expanding access, and we will be the first local health district to introduce the single digital patient record, streamlining clinical information and creating a single view of each patient's care. Through this change, our mission remains clear, delivering better healthcare for healthier communities. Finally, I really want to thank our staff and volunteers across our district. Your skill, compassion, resilience are deeply valued by myself and the board. Everything we achieve comes down to the commitment that you show to the communities that we serve. So with that context, I'd like to hand over to Tracy, who will take you through the year, what challenged us, what we changed, what we improved. Thanks, Tracy.
Good afternoon, everyone, and thank you, Kirsten, for the introduction. It is a pleasure to be here and I appreciate you joining us today. Hunter New England Local Health District is one of the largest and most diverse local health districts in New South Wales, and we care for almost 1 million people, from southern Lake Macquarie to the Queensland border and as far west as Narrabri. Our district includes more than 100 hospitals, community health centres and multi-purpose services, providing care across metropolitan, regional and remote settings. With more than 20,000 staff and volunteers, the size, diversity and commitment of our workforce is what makes everything possible. This past year has been one of the most challenging and across the system and here in our district. The demand continues to grow. Workforce shortages have stretched capacity and financial pressures have required difficult choices. We've seen long waits in our EDs and for surgery, but also steady improvement through extra theatre sessions and network coordination. New recruitment strategies filling critical roles, particularly in rural and regional hospitals. Expanded local health committees to give our communities a voice. Expanded virtual health and community partnerships, bringing care closer to home. And restructured clinical operations to strengthen networks and consistency of care. This year, we've also been active in shaping the conversation, participating in the Special Commission of Inquiry into Healthcare Funding, which is examining how funding is distributed across the health system, and responding to a parliamentary inquiry exploring whether Hunter New England Local Health District should be split into 2 separate districts. Whatever the outcome of these processes, our focus remains on delivering equitable, high-quality care across rural and regional communities. And our results this year show steady progress against those standards, even in a challenging environment. Our performance is assessed against the New South Wales Health Performance Framework and Services Agreement. These benchmarks define what good looks like for every local health district, from emergency timeliness to surgery, length of stay, and virtual care. Some targets are met, others remain stretch goals, but our trajectory is positive. There were slightly fewer emergency presentations overall, but 10% more patients admitted. That reflects higher complexity. Nearly 20% of patients admitted were transferred to a ward within 4 hours, which is against an 80% target. So below benchmark, but still consistent with system-wide pressures. Transfer of care improved to 75.4%, which was up to 2.6%, but still below the 90% target. The average length of stay in the emergency department is 5.5 hours, which is slightly over the 4-hour benchmark. But our larger hospitals, John Hunter and Maitland, saw highest ambulance growth, showing continued demand for our major sites. Admissions increased by 5%, showing significant activity growth, and our average length of stay dropped to 5.1 days, which actually meets the benchmark. Discharge before midday improved to 33%, so nearly at the 35% target. And day-only admissions rose to 6.3%, reflecting better use of our capacity and throughput. In surgery, the state target is 0 overdue elective procedures. By June this year, 25, Category 1 is now cleared. Category 2 and 3 lists have significantly reduced, and they were 157 and 280 respectively. The theatre activity is up 5%, including 3,800 additional procedures, and equates to 2,100 extra theatre hours. It's a continuing challenge as patients are waiting in hospital for aged care and disability placements, which is really holding up availability of beds. Our care also extends to community and virtual care, so beyond the hospital walls. And more than 5.1 million outpatient appointments were delivered this year, and over 660,000 virtual consultations. The service agreement sets a 30% target for non-admitted activity to be delivered virtually. And we're not there yet, but we are showing strong growth, particularly in rural areas. Expansion of programs in oral health, pharmacy and opioid treatment continues to improve access and equity across communities. And we'll continue growing virtual care towards that 30% target. We've embedded a district-wide performance improvement plan to sustain our progress. Initiatives such as transit lounges, short stay units and surgical review programs are improving patient flow. And we are piloting a culturally led care coordination model to support Aboriginal patients after discharge from emergency departments. Led by our Aboriginal health workers and practitioners, the program provides early follow-up and practical support to ease the transition from hospital to community care. So all of these numbers show the breadth of care and delivered right across Hunter New England, from acute hospitals to community-based services. They reflect not just volume, but system performance and how we're adapting to meet higher demand and deliver care more efficiently. 454,000 emergency presentations, with demand remaining strong in our major hospitals. Nearly 80,000 surgeries performed, which was a 5% increase, demonstrating both higher demand and better use of theatre capacity. Over 231,000 patients discharged, supported by improved patient flow and same-day care models. 8,825 babies born across our district and 20,000 staff and volunteers. 112,000 ambulance arrivals to facilities across our district and 5.1 million outpatients, as I've said. Virtual health continues to grow rapidly, especially across rural and regional areas where travel and access are key barriers. These figures represent a fundamental shift in how healthcare is delivered, bringing services closer to where people live and work. But the numbers tell us an incredible story about scale, reach, and delivery. Behind every one of those stories is a person, a patient, a family member, a staff member, or volunteer. What truly defines our district isn't just what we do, but how we do it, and kindness is what people remember most. It's the quiet gestures, a reassuring hand, a patient conversation, a colleague stepping in to help. While these moments can be measured, they can't be measured, they make all the difference. To close this section, we wanted to share a short video that captures this spirit, the everyday kindness and compassion that connects us all across Hunter New England Local Health District. Because while our performance tells one story, this is the one that truly shows who we are. Let's take a moment to see what all of this looks like in real life through our volunteers at Maitland Hospital. That's what it's all about, people caring for people. It's a reminder that kindness underpins everything we do, even as we manage the realities of running one of the largest health districts in the state. We'll now turn to our financials, which will be presented by our Executive Director of Finance, Tony Gilbertson. Throughout the discussion, you'll also hear from several of our executives as they share highlights, not just from their own areas, but from right across our organisation.
Thanks, Tracy. Good afternoon, everybody. Do apologise, I've got a bit of a cold at the moment, so I'm just battling a sore throat, so I apologise for that. Yeah, the great stories that video of kindness is always a lovely one to see. I guess an important part of us as an organisation, though, is being good stewards of the funding we receive. Hunter New England receives or incurred expenditure around $3.2 billion last year, so we're a very, very large organisation. For context, that's around about 10% of the state's health budget, which is around $35 billion. So a substantial amount comes to this district. I guess balancing the care cost and sustainability is an important part of the day-to-day work we do. And like many districts and many businesses for that matter, we are experiencing the same sort of struggles in terms of operational expenditure is increasing at a rapid rate. And the other complexity, I guess, for us as a district is the scale and diversity of our region. Our financial statements were audited by the Audit Office of New South Wales, and they returned an unqualified audit opinion. So that's a clean bill of health, basically, with no material misstatements. The audit opinion, as I said, was unqualified. As I said, expenditure around $3.2 billion. The bulk of which, or a large percentage of which, goes into our workforce and our VMO costs, around about 2.1 billion or 65%. And I guess in addition to the main sort of things that happened this year with our results, we revalued our assets to the tune of $246 million. Certainly cost pressures, as I mentioned earlier, do continue across the whole sector. We are particularly experiencing cost pressures across our premium labour. We have huge amounts of demand for a variety of our services, particularly our acute facilities. And then our large geography creates the pressure of transport costs and moving patients and services around across a very large district. What we are doing, though, is we continue to apply conscientious approach to managing rosters well, refining our discharge processes and improving length of stay to the best of our ability, and also using our theatre capacity so that our assets are not sitting idle. Our financial sustainability enables us to look into the future confidently to continue to deliver these services. Sorry. Just lost my place there. Sorry about that. Moving on to next slide, Dash. Thank you. So excellence in our strategic plan. So excellence every patient, every time has been, I guess, the foundation upon which the district has delivered services over a number of years now. It's built on a simple vision: healthy people now and into the future. The strategic plan is centred on 3 goals that set out our direction: delivering integrated care closer to home so that patients can access the right care at the right time, ensuring world-class clinical services are supported by innovation and evidence, and building a future-ready health system with strong governance, digital capability and sustainability. Under those goals are 6 pillars that define our delivery. They are, as you can see on the slide there, community, so partnering to improve health and wellbeing across all stages of life; patient safety and quality experience, which you'll hear shortly from Mel O'Brien in some more detail; service, improving access, timeliness and coordination across hospitals and community settings; and resources. So again, using every dollar we get as wisely as we can to achieve the best outcomes. And importantly, investing in the future, so delivering not only major infrastructure now, but obviously innovation and digital transformation going forward, and obviously SDPR, the single digital patient record coming online in March next year, is a key part of that. Staff and workforce culture is also an incredibly important pillar of excellence, and supporting, developing and recognising our people is the cornerstone of that. This current plan is in its final year, and we're using staff and community engagement to shape the next phase, building on what works, addressing what we've learned, and setting new priorities for the next 5 years. The focus remains clear: every patient, every time, supported by a workforce that's capable, connected and compassionate. So let's take a look at these pillars now, and I'll hand over to Mel O'Brien, our Executive Director of Clinical Governance.
Thanks so much, Tony, and good afternoon, everyone. I'm very happy to be able to speak about this next project, particularly. The community pillar is about prevention, early intervention, and partnering with communities to improve health across all stages of life. Speak Up, No Shame was co-created by Aboriginal elders and communities in Narrabri, Armidale and Uralla to address bladder control issues, a sensitive but common health concern affecting 1 in 4 adults. Using Aboriginal-led research and yarning on country, the project created culturally safe spaces to talk about continence, reduce stigma and improve access to care. Community members chose the language, imagery and messages, no shame and don't be shame, used across posters, shirts, videos and web resources. The campaign is now visible in 29 emergency departments and across community settings, with elders proudly leading conversations and encouraging others to speak up. It's become a model for authentic Aboriginal-led health promotion that empowers community voice, improves health literacy and drives cultural change. Healthy Beginnings for Kids is improving child and family health in the first 2,000 days through digital preventative care. Developed by our Population Health and Child Family Health Services, the program sends aged and stage-aligned text messages with health tips, reminders and links to local services. It's now reaching more than 10,000 new families each year, embedding preventative care into routine service delivery. Results show higher breastfeeding rates, more timely introduction to solids and increased fruit, vegetable and water intake, along with improved parental wellbeing. Together, these programs show what happens when communities lead and we listen, more engagement, better prevention and healthier starts to life. Patient safety, quality and experience. This pillar is about delivering safe, effective and person-centred care and continuously improving outcomes through evidence-based practices and compassion. IMAP, Improving Preeclampsia Care Outcomes, is transforming maternity care by detecting and preventing preeclampsia earlier. Introduced at John Hunter Hospital in late 2021, it brings obstetricians, midwives and sonographers together for the first trimester screening using the Fetal Medicine Foundation algorithm. The first of its kind in Australia, IMAP has expanded to Moree and Narrabri hospitals, improving access for regional families. It combines blood test, ultrasound and clinical risk factors to identify women at risk sooner. Notable outcomes include a reduction in gestation at first visit from 20 to 12 weeks, increased Fetal Medicine Foundation screening rates from 3% to 64%, and a 49% reduction in preterm preeclampsia. IMAP is setting a new benchmark for safe, evidence-based and equitable maternity care. Mind and Matter integrates psychiatry into chronic disease and palliative care to support patients experiencing depression, anxiety and distress associated with advanced illness. The model embeds psychiatrists directly within the supportive care for chronic disease team, working alongside clinicians to deliver early person-centred mental health care. This approach improves patient safety, emotional wellbeing and care coordination, particularly for those with complex conditions or living in regional areas. Since implementation, emergency presentations have fallen by 43% and unplanned admissions by 47%, saving an estimated $8.9 million over 2 years. Patients and carers report feeling more supported, better able to cope and more connected to services. These projects prove when care is connected and person-centred, outcomes improve for both patients and the system. I'll now hand over to Elizabeth Grist, our Executive Director of Clinical Services, Nursing and Midwifery. Thanks, Liz.
Thank you, Mel. Good afternoon. It's great to be here and thanks very much for having me. I'm very pleased with this slide. This is firstly, I'll go to the service pillar, focuses on what we do in the district on improving access and equity, ensuring that every person can reach the right care when they need it. The slide you're looking at now is our GP Honorary Medical Officer's Refugee Health Program, and it does deliver compassionate, culturally safe care for people from refugee-like backgrounds across the Hunter and the New England regions. Developed from a small Newcastle clinic originally in 2004, it's now a district-wide nurse-led model supported by volunteer GPs who provide care to newly arrived families during their first 6 months in Australia. The program offers extended appointments, interpreters at every session, and coordinated follow-up, ensuring that no family falls through the gap. Since it began, more than 5,500 people have received care, including 3,000 adults treated by GP HMOs for conditions such as infectious diseases, chronic illness, and mental health. The patient experience is exceptional. 85% rate their care as 4 or 5 stars, describing it as kind, respectful, and life-changing. It's a model of partnership, of compassion, and community inclusion. The Sleep Studies at Home project has transformed our paediatric sleep diagnostics, moving testing from hospital wards to the comfort of home. Launched by the John Hunter Children's Hospital's Paediatric Sleep Unit, the program allows children aged 7 and above to complete oximetry and sleep studies at home for children aged 7 years of age and above, reducing the stress, travel, and the long wait time. The model was co-designed with ENT services, respiratory, Aboriginal health and families to ensure safety, simplicity, and cultural appropriateness. Since it started, more than 650 home studies have been completed, helping children receive earlier diagnosis and treatment. Families report high satisfaction, 98% valuing the convenience, and 86% feeling less stress compared to having a hospital stay. This innovative model is now standard practice, proving that quality, safety, and efficiency can go hand in hand when services are designed around the patient. These examples show how rethinking service delivery creates more equitable, accessible, and family-centred care. Next slide. Thank you. The resources pillar is about using every dollar wisely, improving efficiency and sustainability while maintaining the quality. The outpatient telestroke network delivers specialist stroke care to patients in rural and regional areas without requiring travelling to the John Hunter Hospital. It was developed at the John Hunter Hospital by the stroke team, and the model connects stroke specialists virtually with local stroke coordinators at Manning, Tamworth, Armidale, and Moree hospitals, combining virtual expertise with on-the-ground clinical support. This hybrid approach uses existing staff and infrastructure to make specialist care accessible, equitable, and efficient. It improves the outcomes without additional funding. Since 2018, more than 700 patients have been seen, with diagnoses changed in 19%, medications adjusted in 42%, and new investigations ordered for 55%. The program has reduced recurrent strokes by 45% compared to standard care, while 97% of our patients say they would use this service again if needed. It's a sustainable, scalable model that maximises existing resources to deliver safer, specialist-led care, but closer to home. Gloves Off, Clean Hands, Safe for All is a staff-led behaviour change campaign that empowers teams to cut unnecessary non-sterile glove use, improves hand hygiene, reduces waste, and saves in costs. On average, glove use has dropped by about 30% since this initiative was introduced. On a single ward, that means 85,000 fewer gloves, 2.5 tonnes of carbon emissions avoided, and a 3,500 saving each year, and that's on a single ward. Most importantly, improved hand hygiene has strengthened patient safety by reducing the infection risk. The initiative showcases high-value, low-carbon, evidence-based care and is now shaping system-wide PPE education. Together, these projects show that efficiency and safety can go hand in hand. better for budgets, better for staff, and better for our patients. I'll now hand over to Susan Heyman, Executive Director of Clinical Operations. Thank you.
Thanks, Liz, and good afternoon, everyone. Investing in the future infrastructure. This pillar is about building the infrastructure, digital capability, and environmental sustainability that will define our future. We currently have more than $1.7 billion in major projects underway, including the $835 million John Hunter Health and Innovation Precinct, as well as redevelopments at Gunnedah, Moree, Glen Innes, and many others. We'll be the first local health district in New South Wales to implement the single digital patient record in March 2026, a major step forward in connecting care. Sustainability initiatives are reducing emissions, improving waste management, and supporting environmentally responsible operations. These investments are about more than buildings and systems. They're about creating a stronger, smarter, and greener health system for the future. This year has seen many major progresses in our digital transformation, strengthening the foundations for a safer, smarter, and more connected health system. We've completed the rollout of DMR across all our facilities, fully digitising our paper-based records and enabling the transition to the single digital patient record. We've also introduced electronically controlled drug registers in large pharmacies, replacing paper books and saving considerable time in data collection and auditing. In virtual care, 59 clinics have now transitioned from My Virtual Care to Health Direct Video Call, giving patients and clinicians a more consistent and secure platform for virtual consultations. Across the district, we've increased network bandwidth at 42 regional and rural sites, implemented proper redundancy and backup services, and delivered significant network improvements at Gunnedah. These upgrades mean faster, more reliable access to clinical systems for our teams wherever they work. We've also focused on improving the performance and cybersecurity of our managed systems and applications, ensuring they operate efficiently and securely. Cybersecurity continues to be a key priority. We've onboarded 14,000 workstations to Microsoft Cloud Defender, giving us the ability to identify vulnerabilities in real time. 10,000 workstations have been upgraded to Windows 11 with full endpoint encryption and data sensitivity labelling has been implemented across the district to meet government security standards and to protect sensitive patient information. We will be the first local health district to implement the single digital patient record in March 2026, creating one system for patients and clinicians. SDPR, as it is known, will replace multiple legacy systems with a single statewide platform integrating hospital, community, and clinical information. The program is led in partnership with New South Wales Health and eHealth New South Wales, with clinical leaders across our district shaping workflows and testing functionality to ensure the system supports safe, efficient care. Staff training has commenced with a pilot program at Maitland Hospital. More than 24,000 people will be required to complete training from January 2026. SDPR will provide clinicians with a complete, connected view of each patient's journey, improving communication, clinical decision-making, and continuity of care across all settings. Investing in the future, sustainability. Our district is investing in a cleaner, more sustainable future through district-wide action on emissions, waste and sustainable clinical care. Over the past 4 years, we've achieved a 40% reduction in greenhouse gas emissions, exceeding New South Wales Government interim targets and positioning the district ahead of the state's 50% by 2030 goal. Our progress is driven by a shift to renewable energy and energy efficiency initiatives. Our solar and LED lighting initiatives have reduced electricity consumption by 28% since 2019 to 2020, generating 3.3 million in recurrent savings. Our 10 Water initiative has the capacity to capture 1.4 million litres of water to support irrigation at our sites. In 2025, we phased out desmofrane, an anaesthetic gas 3,700 times more potent than CO2, marking a major step towards low carbon clinical care. Our WasteWise Hospitality in Healthcare project now diverts 2 tonnes of food waste from landfill each week, and an implementation toolkit is supporting expansion across New South Wales Health. At Wallsend, our population health team is replacing short car trips with e-bike travel, saving 65 kilograms of CO2 and boosting wellbeing. Throughout the Net Zero Leads initiative, our clinicians are leading national research into decarbonising surgery, radiography and infection control, proving sustainable care is safe as evidence-based care. Together, these effects are cutting emissions, saving energy and money, and embedding sustainability into the way we deliver healthcare. I'll now hand over to Sharon, Acting Executive Director of People and Culture. Thanks, Sharon.
Thanks, Susan. Good afternoon. I'm really pleased to be able to talk with you about our staff and workplace culture pillar. This pillar is about creating a safe, supportive and inclusive workplace where every one of our people feels valued and able to deliver their best. This is something that's really important to me and to my colleagues. You've heard that we've got more than 20,000 staff and volunteers, and so we're focused on safety, professional development and wellbeing, because how we care for our people directly shapes how we care for our communities. We've just received our annual People Matter employee survey results, and again this year that highlights the commitment of our staff. 88% of our staff say they support the organisation's values, and 70% say that their job provides a strong sense of personal accomplishment. We've also been focused on strengthening cultural safety. 6% of our workforce identify as Aboriginal or Torres Strait Islander, which meets our previous target, but we've just increased that target to 9%, reflecting our commitment to Aboriginal health and employment and to our communities. Across the district, we've been focused on numerous initiatives. We've expanded flexible working, improved access to wellbeing supports, reduced reported threats and physical harm, and launched a new diversity and inclusion plan to strengthen the sense of belonging and representation. We're also building workforce capacity and capability through programs such as our rural relievers, our allied health rural generalists, overseas recruitment and safe staffing resourcing. You can see here some of the scale and the numbers of what we do, including 2,600 attraction and retention incentives issued, 30,000 locum shifts filled, 180 rural relievers and allied health generalists, delivering 116,000 hours. You'll also see that we've invested heavily in the training of our people, and we're proud of the improvements we've made around our staff feeling safe against threatened and physical harm. In addition, we've had over 3,000 jobs advertised and 5,600 positions offered. We're also really pleased with the initiative this year of training our Aboriginal health practitioners as accredited immunisers. This has increased their scope of practice, their professional development, and has further integrated Aboriginal health into multidisciplinary teams. Despite the national workforce shortages and some of the challenges we've talked about earlier, we continue to attract and retain skilled professionals. I'd also like to tell you about one of the numerous programs we've implemented to support our people. This program is the Tamworth Welcome Experience, a place to call home. And it's redefined how we attract, welcome and retain international nurses and midwives in regional New South Wales. We launched it in 2023, and it's designed not just to recruit, but to help new staff and their families to truly settle. I know the value of this personally, having moved internationally with my family. With our program, it involves 3 stages of support: pre-arrival planning, personalised airport welcomes, and ongoing community integration. Before arrival, the recruits receive tailored relocation support to help with planning housing, schools, family needs. On arrival, they're personally greeted at the airport by senior staff, given food and care packs and escorted to their pre-arranged accommodation. It aims to ensure that their first experience of arriving in Tamworth is one of warmth and belonging. And then post-arrival, a customised orientation program focuses on them building confidence, community and professional identity. The results have been fabulous. 77% of recruits have now bought homes, purchased land or are planning to settle in Tamworth. Many partners have also gained employment in local health services and other industries, strengthening the workforce and the local economy. And you can see the participants have rated 9.5 out of 10 satisfaction with their experience. The Tamworth Welcome Experience has been adopted as a district-wide model across hospitals in the district using Virtual Welcome Toolkit. It's a great example of how empathy, collaboration and local innovation can solve workforce challenges and turn short-term recruits into long-term community members. I'll now hand over to Dr. Anand Swami, our Executive Director of Mental Health Services.
Thanks, Sharon. I'm very happy to talk about our approaches in this district when it comes to working with our communities. Any strategy without lived experience risks missing the mark. Our communities keep us accountable, ensuring decisions are grounded in real experiences, not assumptions. We don't always get it right, but we are constantly trying. We have 20 established local health committees that meet regularly, along with several partnering with consumers committees across the district. Together, they ensure the voices of patients, carers, families, and community members are heard at every level of our organization. Work is also underway to re-establish additional local health committees, so every community across our region has the opportunity to actively contribute to local decision making. More than 120 committee members shared their time and expertise to provide insight into service experience and local needs. Their feedback directly influences how we design, deliver, and evaluate care. We place a strong emphasis on partnership, listening to and working with consumers, carers, and community members to enhance the quality and safety of healthcare. Their lived experience helps identify opportunities for improvement and guides the development of more effective policies, programs, and services. In recognition of this, we now offer remuneration to acknowledge and support their contribution. We also use co-design approaches to shape how services are planned and delivered. For example, the Residential Eating Disorder Centre in Charlestown. It was co-designed with consumers and carers. The facility and model of care are built around dignity, inclusion, and wrap around multidisciplinary support. Work has also been carried out with regards to the Aboriginal health governance to strengthen local accountability, cultural safety, and clear pathways to care. Everyday service design, feedback from committees has informed signage, wayfinding, and patient information to make healthcare easier to navigate. Redevelopments. Community members contribute feedback and design input for new facilities, ensuring they reflect local needs. Mental Health Lived Experience Participation Unit. With regards to this, we work closely with more than 40 consumers, focusing on governance, service design, and evaluation. These partnerships between staff and community are what make our district strong, responsive, and trusted. Thank you. I'll now hand over to Ashley, who will take us through questions.
Thank you so much, Anand. So with that note, we're going to go to some questions. Now, we have had some that have been pre-submitted that I'll get to first, and they're slowly coming through. But just a reminder, if you do have a question, you just need to go to the Q&A function on your screen and ask it that way. We've turned off chat just to kind of streamline some of those. Two things before we get started. The first is apparently the sound on the kindness video was not working. Thank you for all of the messages. I do appreciate it, and I'm very sorry that that didn't work. So we will have that on our social media channel. We have promoted it previously, but it's on there if you wanted to go and take a look. It's a beautiful video of our volleys out at Maitland and the incredible work that they do. The second is now you've just heard about some of the projects that were winners in this year's Excellence Awards. So congratulations to all of those teams. These will be put forward to the New South Wales Health Awards next year and just showcase really great examples of innovation, creative thinking, and different ways of working across our district. So on that, and while we have some questions come through, the first I'm going to ask is, I'm going to put this one to you, Tracy, is what are the district's top priorities heading into 2026, and how do they align with our long-term strategic plan?
It's like a prize thing you're announcing, like who was going to get the first question. So our strategic plan actually finishes at the end of 2026. So we were about to start a process that develops a new strategic plan for the 5 years starting 2027. So I don't imagine that our long-term strategic plans goals will change too much. So I'll talk mainly to our priorities, our current priorities, which I suppose the big overarching immediate priority is for us to ensure that the single digital patient record is rolled out successfully. This is a game changer, especially for Hunter New England, who probably has the least digital and most paper involved in its medical records. So it's going to be a great change for us, but it is a big change. There'll be a one night in March 2026 where everything in the old system gets turned off and everything in the new system gets turned on, and fingers crossed we'll be ready and it'll all work brilliantly, and our clinicians particularly will have a much better access to digital records and handheld devices. But the plan is for the whole of the state that we're first, Hunter New England is first, but then they'll roll it out through other local health districts. So eventually by 2029, people who present at any hospital across New South Wales, the clinicians will be able to access their medical records, and there'll be less chance of mistakes, and also limiting the need to retell your story no matter where you are. And this is certainly very important in emergencies that occur when you're out of your own area. So certainly single digital patient record is a priority, and another immediate priority for 2026 is to commission the new acute services building for John Hunter Hospital. This is a very important building for the whole of the district because John Hunter is our tertiary referral hospital and does all of that level 6 really high level trauma specialty work for all of the district, and actually even north of the district in other parts of the state. So we'll have additional space and beds in a new emergency department, additional operating theatres, a new neonatal intensive care unit, a paediatric intensive care unit, an adult intensive care unit with some other additional clinical spaces. So that is a big move for us, and so we'll be concentrating on that. But our sort of longer term, I guess, priorities are workforce. Workforce is our biggest challenge, and the more rural and regional you get, the harder it is to have a sustainable workforce. So we're still working on strategies to ensure that we have sufficient qualified, accessible workforce to provide services to our communities. And where we don't have that, our other priority is to extend our virtual services. And that's not just about workforce, but it's part of the driver. But there's also a real understanding that communities and patients would like services delivered closer to their home, and virtual services make that possible. So we're spending a lot of time trying to perfect. We've already got substantial and significant virtual services available, but we really want to extend that. And we're hoping that that stops people having to present to hospitals, stops people having to travel for specialty appointments when they can achieve everything they need to achieve virtually. So that's a big one. Embedding our new model of care that's being led by our Aboriginal Health Unit, which is providing some real case management for Aboriginal people that present and have procedures in our hospital or present at the emergency department, and when they get discharged, we want to make sure that we get them home on country, so where they can best recover and get rehabilitation for any of their procedures, but also make sure that we've got really good follow-up, because we are aware, sadly, that a lot of Aboriginal people don't necessarily feel comfortable or safe in some of our hospitals. So we're also working on that, and we're working on getting a new understanding, a code of conduct. So we're really looking at sort of how we address racism and any forms of racism in our organisation, because it is so important. So that whole Aboriginal health piece is also a priority for us. So that's the top of mind ones. Obviously, we've still got some work to do in our performance. We want to reduce those waiting lists in surgery. We want to reduce the time people wait in our emergency departments. And we want to continue to make sure that we provide the safest care possible. So all of that is part of our everyday, but still, we prioritise all of those things every day.
Lots of priorities, and you touched on quite a few of the questions that have come through, so we might have to go back to them, but that's okay. So we did have a question which was around the introduction of SDPR, our single digital patient record, and it changing patient care and staff workflows, and would patients experience anything different? Tracy, you touched on the point that medical records will be accessed from any facility within the district, and it's that retelling of your health information, much simpler approach. So we might not go back to that one. There is a question, we're going to change just approach a little bit. You touched on sort of challenges that we're facing in meeting emergency and surgical benchmarks and how we're addressing them. I just wanted to touch on John Hunter Hospital and the acute services building. Will that help to address some of these challenges that we're facing?
It will help us address some of the challenges we're facing. Certainly, there will be more beds in the emergency department, so that we will be able to offload from ambulances more quickly. I think the concern we have, and I know that the community is very aware of stage 2 of the John Hunter Innovation Precinct or development, which was the second part of the master plan, which was to provide modern state-of-the-art inpatient beds, but also additional inpatient beds. Part of the problem we have at John Hunter is that we're full all of the time, and in fact, we're over full. We've got a thing called surge beds. We're often got, up to 20, 40 surge beds open at any one time. So that's not the most efficient way or the most effective way to run a hospital, but it is what we do so that we can try and provide the access that people need. So we are talking to the Ministry of Health about how we can plan this next stage that we need for additional inpatient beds.
Thank you. And just on a topic around capacity, and Susan, you might also want to jump in on this one, but we've had a question around how we're addressing delays in aged care and disability placements that impact hospital bed availability.
Yeah. Do you want me to jump in, Tracy?
Yes, that's fine.
Okay. Look, we've got a number of initiatives to try and address that, and I certainly know that the state is also in conversation with the Commonwealth, which is a really important thing for us to keep in mind, because this doesn't just affect Hunter New England, it affects hospitals right across New South Wales and in fact right across the nation. So it is a Commonwealth issue to be dealt with. Having said that, locally we've got, for example, one of the initiatives is at John Hunter Hospital, where we've invested in a designated social worker and a designated OT who work as part of a specialist team to really target looking at how can they assist elderly people who are in hospital and who no longer need to be there for their health reasons to access the right care outside the hospital. And that takes quite a lot of intense continuous effort to make sure that these people are transferred out of the hospital into the right care as soon as they can. It's at the moment, that's only been going a few months and we're seeing really, really good results. So that's something that we'll also look at replicating across the district, either by a virtual model where we have, for example, virtual allied health who can assist in the smaller facilities, or where we have some more on-site allied health to provide that.
Thank you very much for that, Susan. We'll just go to a question around that we've received from one of our local members, and it's around the number of local health committees that we have across our district, and how many should there be in total? How many do we have coming currently up and running, and getting the remainder up and running? So Tracy, did you want to take that one on?
Yes, sure. We've currently got about 20 active local health committees meeting regularly. I know some of the local health committees that were up and running prior to COVID sort of shut down when COVID happened, and some of them hadn't been sort of restored. So we're concentrating hard on doing that. There's no number that we have to have. I think there's some guidelines around just ensuring that local communities are well represented, and sometimes that is practical. The towns or the areas are big enough to have one local health advisory committee for them. Some of them that are more remote, we might want to try and sort of get a few different facilities and join them together and sort of create a sort of combined local health advisory committee. In 2026, we are targeting to support some new committees, and we put additional resources into making sure that these local health committees are supported appropriately. So we're looking to establish new committees in Cessnock, Kurri Kurri, Glen Innes and Quirindi in the first instance, and we've just recently established one in Weewell. So we'll be looking for the areas and certainly be open to hearing from local MPs and local communities that if they don't have an LHAC, as we call them, Local Health Advisory Committee, then we certainly will be happy to work with them to establish one.
Thanks, Tracy. I know we have a couple of local health committee members on today's annual public meeting, so thank you very much for joining us. And I just want to acknowledge Sophie Scott and the work that she does with our local health committees. It's great to see them up and running and so engaged. So thank you for that. Now, I'm just conscious of time. We are slightly over. I just have one more question that's come through. One or two questions, and then I'll get everyone going. The first is actually for Tony. So are there any examples of efficiencies or innovative approaches that we've adopted this year to help ease the financial pressure without compromising care?
Yeah, I guess, well, look, we've got around about 16 or 17 key efficiencies that we're focusing on across the district. Probably the ones that are easy to talk to in terms of understanding what they look like would be improving rostering practices. So there's been a large body of work we've partnered with our colleagues in people and culture around some of the better rostering practices across the district. And I guess that's the aim of that really is to ensure that staff are rostered appropriately, but also in a way that ensures we, where possible, maximise opportunities for leave, rostered ADOs, as well as, gives the district the best financial outcome in terms of how we roster those staff. So that's probably been one of the major ones. The other one that probably stands out in terms of success has been a real focus on, where possible, utilising single rooms to sort of drive revenue. So we obviously receive funding from the government. The bulk of our funding comes through an activity-based funding model, and I won't go down that rabbit hole, but we also generate our own revenue through having private patients in public hospitals, and where we're able to, where clinically appropriate, give those patients a single room. There's a premium for that as well, and we have focused on that as well.
Thanks, Tony. I know there's a lot of work going on around particularly the rostering practices. I've seen a lot of communications on those, and it's good to see that there's been some traction. Anand, I've got a question for you, and I only have 2 left, so bear with me. This question is, we often hear about the lack of mental health services for people needing mental health help. Is our district looking to create more mental health beds or inpatient units, or how else can we or should we manage this community need?
Thanks, Ashley. It is a challenging aspect, and there are perhaps there's more complexity to it. When we speak about access to mental health services, there are perhaps different layers to it. One aspect which we tend to get through feedback is around the interface between specialist services which are provided by the district and perhaps primary care. So what we try and do, and that's particularly set within the strategic priorities for the mental health service, one of the key components we are looking at is partnerships with the PHN and external agencies, because quite often we find that there is access to services in a number of areas, but it's about how to access them and being able to do it and to make sure that people don't fall between the gap. For that, we need to strengthen the partnerships with the PHN and the external service provider. So that's something which is in the front of our mind, which we have put into our strategic plan going forwards into 2026. So that's a key initiative we have. So we're working closely with them. And there's also the regional plan, which has just been reviewed recently, which is a partnership between Central Coast, Hunter New England, and the PHN. So a number of those themes have been captured through that, and that was done through multiple forums and engagement with the community and relevant stakeholders to identify the gaps and come up with potential solutions or avenues we need to explore going forward. So that's one part of it. The second part, which relates to the hospital care and beds, that is a consistent challenge. We do have periods when there is peak demands. It is reasonable to take a view that over the last year, particularly, that the demand has been higher than preceding years. It is something which we continue to work on. The ministry has also been looking at hospital in the home models within mental health. And there is currently a couple of trial projects which are going to start in the state, but they are with different districts. But the hope is that these are newer, innovative models which will come into play over time and also allow us to deliver care for people in the community closer to home as much as possible as well. So I do think this is a new initiative which we need to look forward to. But at the moment, that's not available in Hunter New England. As an alternative, we do have other working models in the community called acute care teams, where we can try and help people in the community, even during an acute phase, and try and avoid admissions which may sometimes not be preferred by people who receive care as well. So there are multiple different approaches which we're working on, but it is a need. We acknowledge that, and it's something we continue to work on.
Thanks, Anand. And lucky last question. I'm actually going to direct this one to Sharon and Tracy, Susan, anyone, feel free to jump in as well, which is, how is the district supporting staff wellbeing given ongoing with some of the workforce shortages that we've seen and the increased demand for services? So I'll throw that to Sharon.
Thanks, Ashley. That's a big question. We know that wellbeing challenge is a complex one, and I think we've got a range of ways in which we're continuing to address that. So, obviously you've heard, as we've talked about, a range of things we're doing in terms of staffing initiatives and ways in which we are making sure that we have got enough people, including things like overseas recruitment, various ways in which we're using all sorts of forms of casuals and permanent staff. We've had some really good results this year in terms of increasing flexibility and good feedback from our people around that. So that also helps from a wellbeing perspective. There's quite a lot of focus on leave and ensuring that people take leave and creating opportunities for people to do that. Over the last year, we've also refreshed a range of the resources available to our staff around wellbeing and made that more visible. We have good usage of our employee assistance program, which provides support around that. Also, wellbeing is a key focus of our People Matter employee survey, and that provides the voice of employees around wellbeing on a number of different elements down to a team level. And so as part of leaders communicating that and working with their teams on action planning, I think wellbeing is also quite a large focus for teams in terms of working through what they can do on a team basis with their leaders and exec around addressing those challenges. There are a few things that come to mind.
You have, I'm sure, a very long list of initiatives. Thank you, Sharon. I might just, given time, I'm going to pause there and thank you for all the questions. I'm going to hand over to Kirsten to wrap us up and close us out.
Thanks, Ash, and thank you to all of the executive for sharing these updates and highlighting the important work that's underway across the district. There is actually much more going on. It's a snapshot, but it's an extraordinary amount of work. The past year has been one of resilience, innovation and progress for Hunter New England Local Health District. And together we've strengthened our foundations and built momentum toward a health system that's more responsive, inclusive and sustainable. As Tracy mentioned, our current strategic plan nears its end in 2026 and planning for the next 5 years is underway, building on what we've achieved, but also responding to the challenges we've faced and to keep us focused on delivering safe, sustainable and patient-centred care for our communities. Finally, I want to reiterate my thanks to our 20,000 staff and volunteers and our community partners. It's your skill, compassion and commitment that makes all these achievements possible. And I want to thank everyone for joining us today. Interest and support means a great deal, and we look forward to working together as we continue to shape the future of healthcare in our region. Thank you very much.